Now we're going to talk about mammographic architectural distortion and how DBT can help us identify distortions on mammography. Architectural distortion is defined in BI-RADS as distorted appearing parenchyma with no definite mass visualized. This includes thin straight lines or spiculations radiating from a point. It can be focal retraction, distortion, or straightening at the anterior or posterior edge of the parenchyma, but also may be considered an associated feature within BI-RADS with asymmetries, masses, or calcifications. In this case demonstrated here, we have a spot MLO projection, and you can see here there's some distortion in the upper breast with some radiating lines coming out from this sort of central point. This was later subsequently biopsied as a large invasive ductal carcinoma at this location. Common pathologic entities associated with architectural distortion, of course, include malignancies, particularly invasive ductal or lobular cancers. And architectural distortion tends to be a marker of more slow-growing malignancies. It's related to that desmoplastic response, which causes the distortion to appear. You can also see high-risk lesions, such as radial scar or complex sclerosing lesions with atypia. In addition, we can also see benign findings, so post-procedural scarring from excisional biopsy, lumpectomy, or reduction surgery, also fat necrosis or sclerosing adenosis or fibrosis. These can all lead to a distorted appearance. And in some ways, at least particularly for the benign findings, the clinical history is also really important to evaluate when you're looking at these exams, either given to you by a technologist or if you're doing a diagnostic exam when you're talking to the patient. On imaging, architectural distortion can be difficult to detect in some areas of dense tissue. Conventional 2D imaging, this may be a significant source of missed malignancies. Of course, if it's a very large area of distortion, it's not hard to miss at all. But distortions are more readily identified with tomosynthesis, and approximately 73% of identified distortions are seen at tomosynthesis only, so not on the SM view and not on the associated 2D view if you're acquiring that separately. Tomosynthesis may also more readily identified with an associated mass, which may raise suspicion for an underlying malignancy. Importantly, there are no definite imaging features which reliably distinguish between benign and malignant distortion. So basically, any distortion that you see needs to be worked up and further evaluated, or at least determine what might be causing it. If you can prove that a patient has had a prior surgery at the location where you're looking at a distortion, either by using a scar marker or sort of clinical history, and that can really help you to put that into a benign category. But without that definite history, you're pretty much stuck doing some kind of further evaluation. And usually that's going to lead to a biopsy if the distortion is indeed real. Tomosynthesis may also aid in localization of architectural distortions that are initially only visualized on one view. This does happen. Of course, we have to use the scroll bar to help us do that. And we know that there are certain aspects of the scroll bar we need to be careful with in terms of lesion localization. Tomosynthesis can also help us by identifying adjacent anatomic landmarks. That's either like sort of an area of focal fibrillary tissue, for example, or maybe a distinct coarse calcification that's nearby. You can use that to help you determine where in the tomosynthesis stack you're going to find your area of distortion, if it's solved. So in this case, we have CC and MLO spot compression views on either sides of the screen, and in the center, a full field MLO. Now, you might see there's some maybe potentially distortion down here in this full field MLO view, but it's very difficult actually to see in these SM views. In fact, I probably wouldn't say you see very much at all, other than some heterogeneously dense tissue. But as we scroll through the tomosynthesis, you can get the sense that there's maybe something more here with some radiating lines coming out from a central point, and also up here on this full field MLO view. But on this MLO spot compression view, we can really see this a lot better with some radiating lines here, potentially an associated mass located centrally here. In terms of management, as I mentioned, correlation with clinical history is really critical to rule out benign causes. You can ask the patient, search for prior history or documentation. You need to complete the diagnostic exam with spot compression views. Focused compression may improve visualization of the distortions. However, we have seen some cases too where spot compression actually causes subtle distortions to resolve entirely. So sometimes repeating the full field view can be helpful, or if you have a high index of suspicion based on just on the screening exam, it's important to go ahead and do the diagnostic ultrasound where you think the lesion might be, because I have had at least a couple cases where we see it really well on the screening exam, but the patient presents for diagnostic imaging, doesn't look very exciting at all. We end up going to ultrasound and find a malignancy right where we expect it to be based on the screening exam. So diagnostic ultrasound is recommended for all suspicious distortions. If a sonographic finding is present, then of course ultrasound guided biopsy is the way to go. If there is no sonographic finding and you're still worried about the distortion based on the mammographic views, then of course stereotactic biopsy is recommended. And we had the benefit of having DBT or tomosynthesis guided stereotactic biopsies to make that sort of biopsy even easier to do.